Kind of be back a bit. It's been a couple of years since I actually had meaningful interactions with folks out in Hawaii. I miss it. I'm in Virginia these days. Why would I do such a thing? Well, I got priced out among many others. That's the honest truth. Cut right to it. But Hawaii will always have a special place in my heart. So I enjoy these kinds of things when they come up. So today we'll be talking about ethics yet again. We may or may not get through every single principle. It's more important that we have a meaningful chat about a principle. If we happen to get through all 12, that's wonderful. If we don't quite make it, you all have the information. You can read it again if we don't quite get them done on time. Next. Couple quick notes about me. I will not spend much time on that because that's probably not what you're concerned about. I am licensed in quite a few states, including Hawaii. I've got my national certification in CSAC and a few other things. Who cares? Spent some time at Ku'aloha Olamau. Was a counselor there. Went to clinical director for a bit. Moved over to Explore Counseling, became their assistant director before going solo. Now I'm in Virginia doing private practice slash EAP contracts. Next. A couple of references there. Primarily, we're talking about the code of ethics associated with the CSAC application, which is a certified substance abuse counselor credential based in Hawaii. That code of ethics is based very largely from the NADAC code of ethics. You'll notice there's quite a few overlaps with codes of ethics from ACA, NASW, and many others. Next. And the links to several codes of ethics are embedded in case anyone wants a reference. So it's not just Dave's opinion. These are based on actual codes of ethics. That's important. One of the actual codes that we'll get to talks about backing up what you're saying with actual objective data. And that is quite important in our field, of course. So Principle 1 talks about non-discrimination. It reminds us that we should not discriminate against clients based on race, religion, age, gender, disability, and so on. Essentially, all those protected classes. Use a little HR/social work lingo, but as a healthcare professional, that's something I would think we're probably familiar with. So if a person comes to enter treatment with us in any capacity, whether substance abuse or not, we should not turn them away simply because of one of these protected classes. The one that's a little bit arguable, to be fair, is disability. And if anyone wants to chime in and give thoughts or questions, feel free to do so as we go. I do value participation as we go, as you might get bored with my voice over the course of approximately an hour, and I'm okay with that. I understand. Disability is a very vague term. If anyone's willing to share, what are some scenarios in which a person's disability might make them unable to attend service as you offer it? What comes to my mind, for example, when I worked at Ku'aloha, which was a medication-assisted treatment center, it was an outpatient level. Some people referred to it simply as a methadone clinic. I didn't love that lingo, but I know what they meant by it. We were up on the third floor of the building. There were stairs. There was an elevator. Unfortunately, the elevator would not always work. So what if someone can't hike the stairs? We won't turn them away and say you're not welcome here, but I can't personally fix an elevator. So what do we do? If the elevator's down and the client/patient arrives
Did
for
you
their
hook it
medication,
downstairs?
we would, yes. What we would do
Oh,
is it certainly made the day come to a screeching halt, but the nurse would need to package up that person's medication in a very specialized way because this is all very regulated up to DEA and SAMHSA, up to the Fed level, lots and lots and lots of red tape, as some people call it. And there was a controlled way to go down with a witness and give that medication to the person where they could receive it. Now, we did unfortunately run into some challenges with privacy because at the bottom of the stairwell was the sidewalk that was very visible to everything else in the essentially shopping center in which the location resided. So now the neighboring businesses see client X receiving medication. Now, in theory, they know they receive treatment here. Can't do much about that. That was the compromise that we had to make. So we did not turn them away based on disability, but we realized that they still need what they need. They still need the service. They still need their medication. If anyone's not somehow familiar with opioid withdrawal, there is a significant, genuine physical withdrawal component that takes far more than willpower to get through. So the medication component is quite important. We're also reminded to avoid bringing personal or professional issues into the counseling relationship, such as any bias that we might have. We should not allow that to change how we deliver service to the client or the patient. Um, and if anyone has thoughts or feedback, again, keep it coming on anything that we talk about today. So some people may have an opinion that's not in favor of things like methadone medication. And personally, you're allowed to have that opinion. Ethically, there's a conflict because it is an evidence-based treatment and it is the most effective treatment for opioid use disorder per all the statistics and empirical data. So as we get later, there will be a principle about public statements that reminds us to be evidence-based and specify when I'm giving Dave's personal opinion versus when I'm sharing based on my profession and actual objective data. But for principle one, we're talking non-discrimination. Essentially, we don't want to turn someone away from service if we have the ability to offer it and they qualify. One of the values from the NASW ethics is service. And an ethical principle reminds us that the primary goal is to help people in need and to address social problems. I would hope we can agree that drug addiction of any kind, including opioid addiction in the speaking example, is a social problem. People tend to behave differently under the influence of mood-altering substances, and unfortunately, that involves committing crime at some point. So it's in all of our best interests that folks get the help they need to be well personally, and that helps society in quite a few big ways. And if a person gets control of their addiction and or other dual diagnosis, I almost say co-occurring, almost dated things, but that would be better for them personally, and there's a good chance that they go back to work and start contributing to society in that way as well, and that the wheel turns round and round in a positive way. We should also be knowledgeable in disabling conditions, demonstrate empathy and comfort in interactions with clients with disabilities. So how do we find a comfort level in something we don't yet have experience in? We'll talk about competency very soon. Think about that for a moment as we go to the next slide, please. And principle 2 refers to the generalized topic of responsibility. We're reminded to exercise objectivity and integrity, maintain the highest standards in service that we offer. They use the word counselor a lot because, again, it's based from the Certified Substance Abuse Counselor Code of Ethics. So please don't be offended if I don't mention your particular title. We were called to respect institutional policies, but we'll take initiative towards improving when it will better serve the interest of the client. Hence the example of methadone medication being mobile temporarily in a special circumstance. Does it compromise privacy? Arguably, yes, it did. We had a discussion. We had a note into the chart about them being informed about possible accidental privacy being compromised. They were more in favor of getting their medication and not being in withdrawal than a neighbor possibly knowing that they came to receive care. They made a decision and we respected it. We have an obligation to help others and obtain knowledge and treatment. So unless you've worked in an MAT setting, you may not know a ton about it. That's not meant as a criticism or an insult. I knew next to nothing about it before I was employed at Kualoha. It is what it is. How do we learn something? We must go learn it. We must go do it. We must experience it and practice it. Facilitate the development of counselor supervised as applicable. So that means if you're in a leadership role, which does not take you long to reach if you haven't realized that by now, you'll be training folks. You'll be developing them. You'll be teaching them. You'll be reminding them, orienting them to company policy, standards of operation, policies, ethical codes that maybe they hadn't seen or forgot. Because by the time you finish that graduate journey, I think we can all agree that it's quite a bit of information that we're charged with learning and retaining, and lots of tests and exams and so on. You may miss a detail here and there in a fallible human brain. We can be honest about that potential. Here's the part that's difficult. Report unethical conduct. What's overlaps with NASW Principle 2.10, unethical conduct of colleagues. I won't ask you to give me examples. I'd like to, but I understand the awkward position that may put you in because everyone knows each other in Hawaii. So if you share an example, you may accidentally expose someone. So I won't ask you to do that. The things I've seen in no particular order, maybe in Hawaii, maybe elsewhere. I've seen people introduce themselves as a title that is untrue, such as I am a licensed marriage and family therapist when they are not in possession of that license. That would be a problem. That would be a misrepresentation of oneself that limits what you can offer and under what setting you can offer. There are obvious supervision requirements and so on. That would be a misrepresentation. If anyone feels like mentioning in the chat box, even if it's just a raised hand or a yes or a no, how many of you have had your client or patient label you as something that you are not? And it doesn't even have to be derogatory. Maybe they call you a therapist and you're not that. Maybe they call you a doctor and you're not that. What should we do about that when that happens? I'm asking for at least a couple folks to answer, hopefully.
Correct them? Clarify?
Yes, please do. Yes. And you don't have to be rude about it. For example, for whatever the reason, I guess I gave off doctor vibes. I am not. I do have more than one graduate degree, but I'm not a doctor. And I would say thank you, but I've not earned the title of doctor. I am fill in the blank with whatever role I was feeling at that time. And it was never any hurt feelings. It went on without any problems from there. So I won't ask you to admit if you feel some stress about correcting them in that way, but it can be done politely without any abrasiveness. And please do so if and when it comes up. Because if you misrepresent yourself, you could be accused of misrepresenting yourself, and an ethical complaint is not something you want to spend time on. It will disrupt the delivery of your service, and it may disrupt your license if you have one. We have no time for it. Another NASW note, the value of integrity and the principle of social workers behaving in a trustworthy manner. If you don't correct that in the hypothetical speaking example, it's arguably the same as lying and not being transparent and not being honest. And that would compromise the trustworthiness, which could complicate the therapeutic relationship. So we definitely don't want to get into that. Okay, let's go to the next slide, please. Principle 3 deals with competence. We're reminded to recognize the need for ongoing education as a component of professional competency, such as a continuing education course. It's right there in the name, continuing education, not repeat the same courses you've done the last 10 years on every time, but continuing education, meaning try to learn something that you don't yet know or refresh something that may have become muddy. Who can mention at least hopefully two or three of you? What are some challenges to continuing education? What are some challenges to diversifying it and not just logging into the cheapest thing and repeating the same courses every couple of years? I'm asking for honesty, no judgment, I promise. What makes it hard to do that?
Money?
Yeah. Money. You probably at the top of the list, money. I have seen in time difference, I see in the chat, absolutely. If it's a live delivered course, unfortunately, those of you in Hawaii struggle because most of them are on East Coast time. And that can complicate the availability of it. And when I was still in Hawaii, I was able to put together some continuing education courses that ADAD had approved for hours for CSAC renewal. And I had a decent catalog, if you will. And I was very pleased to see people from many islands would tune in remotely and not have to purchase tickets and fly and get a car and do lodging. Before you know it, a 6-hour CE can turn into $1,000 or so. And that's just not what needs to be happening. I think we can do better than that. Fitting in the time to go to training, because yes, if you are at training, you're not working. And that represents a conflict to your workspace, to you, to your clientele, and possibly to your bank account. So that can be hard to navigate. Uh, yeah, I see that the answers in the chat box: time, availability, cost, location. Yes, time again and cost again. Absolutely right. And good on all of you for being here, and thanks to everyone for making this very, in my opinion, very accessible and user friendly. So I'm happy to see that. Okay. We are reminded to recognize effect of impairment on professional performance and seek appropriate treatment for oneself or colleague if needed and support peer assistance programs. Again, this is more oriented towards a substance abuse setting. It's not exclusively this, but it kind of implies if you notice a coworker who is not entirely competent for whatever the reason, such as drug affected, obviously that's a big safety concern, and we need to tend to that immediately. I won't ask you to raise your hand and tell me you are or are not comfortable challenging that, but I'm going to hope that you are and remind you that that is what we are called to do ethically, and it will be quite difficult. I would encourage you to grab the supervisor as you do so, because you all probably need to debrief about that after the fact. If the person who's incompetent is your supervisor, that adds another layer to it, of course. Hopefully, the supervisor of the supervisor is available to bring them in as well. And it has happened before. I'm sure some of you have some stories, and I won't ask you to share them, but if you want to strongly, I'll allow you to. But again, I don't want anyone to accidentally name drop or expose someone very specifically. On an NASW note, the value of competence is related here. It's the same name, obviously it applies. Ethical principle mentions social workers practice within their areas of competence and development and enhance their professional expertise. So notice it says practice within the area of competence, but it also says develop and enhance professional expertise. So there's respect given to you don't know everything. None of us do. We can't specialize in everything. There's too many. But if there's a need, then there's a need. So we would do well to go obtain the knowledge slash skill to be able to help our clientele. I've had people tell me I don't want to work with substance abuse clientele. I understand and respect that's not for everyone. I don't know that you can realistically work in mental health and not at all deal with substance abuse matters. I just don't know that that's entirely possible. That's an opinion. You can agree or not with that. I would wager it's going to come up. And the reason I say that is it's very prominent. We know that. But although substance use disorders do have their own diagnosis, they're often arguably a symptom of other things. I've treated tens of thousands of people in a substance use capacity. None of them woke up one day and decided it was a good day to get addicted to a drug. It was an impulsive behavior due to untreated ADHD. It was an attempt to feel better when they were depressed. It was an attempt to calm down if they were anxious. Sometimes it was an attempt to party and let loose because life was very stressful for them and it led to habitual use. There was always a reason other than a conscious choice to get addicted, obviously, but I just want to bring us back to that orientation to understand dual diagnosis is a real thing, and substance use is one of the more common things that occur with these other conditions. Right? Social workers continually strive to increase their professional knowledge and skills to apply them in practice. Social workers should aspire to contribute to the knowledge base of the profession. So I encourage you, if you have a knowledge area in a particular subject that maybe not everyone else has, consider putting on a CE of your own and sharing that wisdom and that knowledge and that skill. It would do benefit to the entire population. Okay, let's go to the next slide. Oh, we may be frozen. There we go. I think we may have. Okay. Did we skip one by accident? There we go. Yeah, principle for legal and moral standards. Not the most exciting of topics, but arguably one of the more important ones. This is where you can get yourself into trouble, slash sued, slash arrested, slash closed down if we don't follow these things. So we are supposed to uphold the legal and accepted moral codes which pertain to professional conduct, be aware of federal laws, respect of state governing practice of counseling. Who can give me an example of a state law that might be different in other states, that might conflict with a federal law, whether it's about substance abuse or anything else, mental health?
Telehealth?
Say again?
Telehealth in general, pay for telehealth?
Absolutely. When I still resided in Hawaii, I was working for Explore Counseling at the time. We had a big military clientele, no surprise. Many of them were getting reassigned to Guam, no surprise. So I called the folks at the Department of Health in Guam and said, how do I help in the nature of telehealth for the folks that are moving over there? If anyone's affiliated with TRICARE, please don't get mad at me as I tell this story. So Guam told me, fill out these forms, send me these forms to prove your training and your supervision and so on. Here's the fee. The board meeting is ever so often. You'll be in line to be considered. Got the Guam equivalent of a state license. As far as I knew, we were ready to go. I called TRICARE and said, do we need to do anything different for credentialing? This is still the West region. However, is this overseas in your opinion? They said, yes, it's overseas. I said, okay, I suppose I need overseas TRICARE credentialing. Please assist. TRICARE overseas credentialing says you cannot do telehealth for Guam. Guam does not allow you to do telehealth. And I said, well, that's odd because I have an email from their board that issued me the license after knowing I live in Hawaii and intend to use it in a telehealth capacity. Perhaps you two should talk. And they said, no, we already know that Guam doesn't allow it. And I said, well, here's the email from Guam that says they do allow it. And TRICARE, it absolutely refused to go for it. Guam had given me the permission. TRICARE did not want to acknowledge it, although I put it in writing and gave them the proof. What can I do about that? Nothing, unfortunately. So we have a big compromise to access to care, even though there's a provider license and able to help. The insurance company had an incorrect opinion. You can't change their mind on that, unfortunately. So I was not able to help. What's the point? Well, in this case, the insurance company was incorrect on a legal and moral matter. Morally, I had a conflict because I wanted to help and I was legally able to help, but one of the gatekeepers had a different opinion and unfortunately the power to negate my ability. So turning that the other way, they're in a methadone capacity. There is a certain number of doses of methadone that a client is able, to leave the clinic with. There is a maximum number. They have to earn them in a certain way. And if they want more than that, basically they can't have it. So the number that the state said they could have was not the same number that the feds said they could have. So which one do you listen to? I'm asking for a feedback from a couple of you if you're willing. Which
Oh,
one do you listen to when
well,
you
the
have a
feds
con?
can arrest you.
Yeah.
Just like
So
marijuana, the feds can always arrest you.
absolutely.
The
So
state,
you want to, when presented with conflicting rules, you want to listen to the one that has the most authority. In this case, that would be the feds. That may hurt our feelings and we may think it's not right. I'm not even going to tell you that you're incorrect. But the feds have the power to come to any state and enforce the federal laws, whether we think they should or not. So we as a clinic could not issue beyond the number that we were told we could issue. If we wanted to ask for an exception, we had to route that through SAMHSA up to DC. They would approve it or they would not. It was up to them. Do you think I had some clients mad at me about that? You better believe it. Because people wanted to go on vacation for a long time and not miss their medication. I understand. Unfortunately, those laws ended up making some clients have to choose between continued treatment or a long vacation. It broke my heart, but I couldn't influence it. Now, if you go ahead and do it anyway and break federal law, good luck to you. because you've broken the law, number one. So your license is probably very compromised. But also, as soon as one person found out you did it for them, other people are going to want you to do it for them, and the word's going to get out, and you're going to have a conflict. It's uh, it's not good. One of many notes that fall under legal concerns, standard 1.03, informed consent as an example of legally required item for the beginning of treatment. I hope that's in your intake packet. And if it's not, you probably want to add that very quickly. I always found it nice when you're running a facility to have an intake specialist or a person or two or a department that handles intakes so that the caseload counselors in concept don't have to go backtrack and deal with those things. Sometimes staffing and organization doesn't permit that. I understand it. If you can do it that way, in my opinion, it works a little smoother. And it makes for nice, clean audits when your records are reviewed because it's in the beginning of the process. Plus, it clarifies everything, and you don't have to go back and spend time answering questions that were not addressed in the beginning. Because we do need the informed consent. We need the permission of the client to treat them. That is a thing. You would think them showing up and asking you to treat them would signal they want you to treat them. You're not wrong, but we do require the legal paperwork to acknowledge that. One of those things. Okay, let's go to the next slide. Okay, public statements. We briefly mentioned this earlier. We're reminded to honestly respect the limits of present knowledge in a public statement concerning alcoholism and drug abuse. Basically, don't go on the news and claim to be an expert on something if you are not. Pretty straightforward. Sometimes we can get excited about a topic that we're passionate about and perhaps accidentally speak in an authoritative way that maybe is not quite warranted. So we're reminded to base statements on empirical data, specify which statements are opinion based. So if you're of the personal opinion that methadone is just another drug, I would disagree, but you're allowed to personally have that opinion. That's not something you want to go on to media and say, as, for example, a substance abuse counselor. You would want to specify that that's a personal opinion, because that would actually not be in accordance with evidence-based treatment. We are reminded to report substantiation and acknowledge sources of information. So not only clarify that your information is objective and empirical, but what source can one look at to verify that? So I've mentioned, I think, two, maybe three times now that medication-assisted treatment is the most effective treatment for opioid use disorder. Well, is that Dave's opinion? It happens to be, but it's because I got it from the resources on SAMHSA's webpage, and ASAM and NADAC have references to this as well. So that would be worth mentioning to a person who may not be well versed in where to find this information. Okay. Now, if a client decides they want to go at an opioid use disorder without medication, they have the right to approach it that way. I want to make sure we mention that and respect that. We are supposed to mention to them that evidence suggests medication would be more helpful in combination with counseling and such, but they have the right to decline treatment and not do medication. And that's okay. So I don't want to make it like I want everyone on medication. That's not exactly what I'm saying. Anyone have any experience in public statements that you want to share? You don't have to, but I want to give the chance in case someone has been in that capacity. And if not, it's okay. Okay, let's go to the next slide and I'll keep an eye on the chat box in case. So principle 6, easy to forget. It regards publication credit. We're reminded to assign credit to all who have contributed to the published material. So let's say you write a book. If anyone that helped you do that should be acknowledged. Anyone who helped you run the experiments, if that's part of what the data is that you're presenting, down to the administrative assistant who helped you compile the data and list the references and so on. they helped. They should get something. Do they get royalties? Maybe, maybe not. That's between you all. But we don't want to cover up anyone's effort that led to the publication. We need to recognize joint authorship or joint publications. We need to acknowledge minor contributions, even clerical. Avoid copyright violations. That's perhaps where we might accidentally violate, and what, in my experience, what I've seen. Avoid copyright violations. Who can tell me where that might happen, even accidentally? And if possible, I'd like to hear a couple people or type or speak to respond to that, because this does happen, and it might be accidental, but it happens. Not listing references, basically, yes. When I used to run group, I would make points that are based in empirical data, and I would bring in the physical copy of the book that it came from because I was primarily dealing with substance use disorder folks. They tend to be skeptical. So here is where this came from. This is not Dave's hip pocket group information. This is based in something. If it was something I could print out without copywriting infringement, then I would print that out and give each a copy. Yes, sources. But some people have been tempted, for example, to take the one workbook that the place purchased and photocopy it and hand it out to everyone. That would be a copyright infringement unless you have obtained written permission from the production source to do so, which you probably have not obtained because they want their money per copy. If any of you use particular workbooks, textbooks, or anything similar as you run your service or groups, if you look closely on it, somewhere on that book, it's going to say do not mass produce without express written permission. Now, if it happens to say that you can mass produce, then go for it and take advantage of it because it's very rare that you see that. It's been a while since I looked at it, but the last time I looked, the curriculum called Matrix, I don't know how they weren't sued by Warner Brothers, but there is a curriculum meant for IOP, a little bit more geared for stimulant use disorders. It's called the Matrix. And it's a pretty solid curriculum. And it does allow for mass printing and reproducing. It's a whole workbook that you can print and give to your clients. It's worth taking a look if you work in that sector. And maybe the budget doesn't allow you to buy single workbooks for everyone. It might be something to think about. Okay, let's go to the next slide. Client welfare, protection of public health, safety, and welfare, and the best interest of the client is a primary guide in determining the conduct of all substance abuse counselors. So essentially, what's good for the client, their welfare. Hopefully that is at the forefront of our efforts and our motivation. If you're ever not too sure what to do, I think this is a good principle to come back to. Client welfare. Now, you could argue what's best for the client. We might have different opinions. Usually, access to care is near the top of the list on what's good for the client. However, as we know, there are times when we need to terminate, and we'll talk about that depending on how far we get. Sometimes it's not a good fit, your particular treatment approach. Doesn't mean either of you are bad, just sometimes it doesn't fit. Sometimes the patient doesn't have coverage to pay for it. Unfortunately, that might mean that they cannot continue unless you have another way, a grant or an allowance for pro bono service and things of that sort. Sometimes they don't have transportation to get to you, and we don't have telehealth. Some of you that live on other islands may not have the luxury of reliable Wi-Fi to do telehealth. The clients may not have a vehicle to come into the clinic, so they don't have internet, they don't have transportation. What can we do? Unfortunately, not a lot. And that is still out there to an extent, unfortunately, and I hope we continue to find answers to that. So we are reminded to disclose responsibilities to the client. I want to ask a few of you to add into the chat box, what are some responsibilities of the client? What's their job as they enter a treatment agreement with us? What are they supposed to do? Because we hear a lot about what we're supposed to do. What's their end of the bargain? What are they doing? Because they need to participate as well. I'd be curious to hear some opinions about what we would advise the client is their role in this process. We are reminded to terminate when it's clear there is no benefit to the counseling service, and that refers to NASW Principle 1.17. We're reminded to hold client welfare paramount when making decisions concerning referral, treatment, termination. So we don't refer only to our best friends because they're our best friends. We refer to the service that they need and that is accessible to them. Yes, one of the responsibilities, thank you, is to report any changes in the treatment or health status. So if your client has a change, then we need to know about it. When I was at Kualoha, we monitored very closely the other medications that they were taking. Anyone want to take a stab as to why we were so attentive to that?
Interactions?
Very much so. Methadone is an FDA regulated and safe medication when it's taken how you're told to take it. Now, if you take too much or too little, it won't work, or you can have side effects. You can overdose. It will interact with anything else that has a sedative effect in an exponential manner. So if someone's, say, on regular methadone and they're on Valium, that's a concern. And that brings up a conflict because those medications together increase their risk of respiratory depression upwards of 10 times. But if you tell someone who's on anxiety medicine that they should not be on anxiety medicine, buckle up. It's going to be an unpleasant conversation. So we would work a scenario to try to safely taper them in a way that did not cause them distress, but would keep them medically safe to be able to manage all their condition. So we needed to know what else they were taking. Who knows what source a prescribing authority can check to see what controlled medications that someone else is on. If you're not a prescriber, you don't touch it. So you may not know, in fairness. I only know because I work right by a psychiatrist. And I don't recall what the letters stand for, to be fair. But the PDMP is a database that every prescriber can look at to see if your patient is also getting Valium from another doctor before they ask you for it. And that's important to know for obvious reasons. What do you think someone might be tempted to do if they get methadone from a clinic and then they get Valium from two doctors and then they get Oxy from another doctor? Other than the danger of them overdosing and dying, what might they be tempted to do in an ill-advised behavior slash criminal nature? Sell it. Yeah, that happens. We like to think the best of our client, unconditional positive regard. Good job doing that. The truth is, unfortunately, old habits sometimes die hard, and we need to keep a close monitor on these things. So we would have what we call callbacks periodically, where we would tell someone, please arrive tomorrow and bring me all your unused methadone. I will not open the bottle. I just need to see it. Each bottle has a date on it on which you're supposed to take it. If you've mismatched the dates, then technically you've misused your medication, and we need to talk about it. If your next 5 days of medication bottles are already empty, we have a concern, of course. So those are all the many things you get to monitor if you work in that type of setting. So it's kind of a big deal. Okay. There's a mention about not encouraging participation in non-treatment activities, but it would have potential harm. I know that's a bit vague, but say a client says to you, I've been sober for 5 years. I've not touched a drop of alcohol in 5 years. I would like to go to the bar tonight and see if I can be strong enough to not order a drink. Would you recommend that they do that? I would not recommend that they do that. So that would not be something I would encourage them to do. That's a pretty obvious one. Okay, provide services in an environment that ensures privacy and safety. I smirk when I say that because I've seen things, as I'm sure a lot of you have as well. I've seen people run session with the door hanging wide open when the door perfectly functions and could be closed and maintain privacy. Why did they do that? I don't know. Privacy is kind of a big deal. Think about it. If you are the client slash patient pouring your heart out to a social worker, counselor, therapist, what have you, doctor, do you want the door open with anyone who passes by the hallway hearing that? Are you going to really be able to genuinely, meaningfully, transparently share? If you can, good on you. Most people would probably struggle with that, in my opinion. I would struggle with that. So, and that's the point of privacy. Now, I have seen some facilities have a policy where the door should remain cracked, meaning closed mostly, but not latched for arguable safety. I didn't love that rule, but I have seen it in places that I've spent some time. If you think your patient slash client is that dangerous, I have to ask the question as to why they're on site. That's just me. Um, so, anyone have input on that one? It's optional. You don't have to, but I like to give the chance. Anyone have a story or an example or a tidbit you think is noteworthy on client welfare, a challenge to client welfare that you've seen? Because in Hawaii, we have a pretty unique dynamic in quite a few different ways.
Well, I've
So
always been told to be on the door side of the patient, but they don't necessarily set rooms up that way. Like, I don't think the architects are told that bit.
they do not. I remember hiring someone at one point, and I told them, and this was on me. I didn't specify. As a director, I said, you may arrange your office how you see fit, as long as you comply with policy and the rules. I did not specify that you shouldn't back yourself into a corner, and the only thing in between, excuse me, the corner of the wall and your desk has essentially blocked you into the corner. Is something going to go wrong in that way? I really hope not. But if it does, you got no chance. That's a safety concern. I did not lead with that. That's where I had room for improvement to expand my communication skills. So we did better from that point on. And I told them, I'm sorry you spent the time arranging it, and I'm sure it's perfect in your mind, but my concern is your safety. That's important to me. I have to insist that we adjust this a little bit. And they saw it, and we didn't disagree too harshly about it, fortunately. Okay, let's go to the next slide. Confidentiality, perhaps everyone's favorite. Um, we need to maintain privacy and confidentiality, of course. Now, the substance use treatment setting, we have CFR 42 Part 2 as an additional obligation on top of HIPAA, for example. There are extra nuances. I would think all of you probably know this, but that's a resource to get familiar with if somehow you are not. This goes down to the nuance of, police showing up saying, I need so and so's record. There's actually a very special subpoena they are supposed to go and get, and they're not going to like it. They may threaten to arrest you, and then you have a dilemma to deal with. But there are very extended additional confidentiality requirements when you're dealing with substance use treatment. There are. And I'm sure we've heard this phrase a lot. I can't confirm or deny. You might get some family member on the phone. You might repeat that quite a few times to them. I've had people come and do an intake together on the same day, two friends. And the next day, how is so and so? I can't confirm or deny. What do you mean? I brought them here yesterday. I know they're here. I can't confirm or deny. Do they know that I know? Of course. But I have to follow what I have to follow. I've had clients who like to do a book exchange, who innocently just like to share books. When they're done reading it, I'd like to leave this with you to give to so and so. I can't confirm or deny. What do you mean? We see you in group every day. If the two of you exist in treatment and decide to sign a waiver to allow me to mention your presence in treatment, I'd be glad to hand the book to them. Should you both find a way to show me that if you exist, I'll comply. That was my rule. And sure enough, I have releases on file to acknowledge presence and treatment. And that's the only way I would do it because I'm just not playing that game. We can't afford it. Okay. I'm not going to spend a ton of time on this one because I'm going to give the benefit that we've talked about this thoroughly and I won't drag it out. So let's go ahead and skip. Client relationships, we're reminded to safeguard the integrity of the counseling relationship by nature of things like informed consent, avoiding dual relationship. This is mentioned in 1.05 cultural competence as well as 1.06 conflicts of interest. Give me some kind of icon if you agree it's harder to comply with not violating dual relationships in Hawaii. Do we think that's a little tougher to comply with in Hawaii? I think it is. You don't have to agree with me, but I think it is. I see it. Okay. Yeah. I would agree. Not that you need my validation, but I did not grow up in Hawaii. I'm not from there birth-wise. I felt at home there when I was there. I spent extended time there and I loved it. It didn't take long before I felt like I knew everyone on Oahu, even though I did not grow up there. Why do I mention that? I've had family members by marriage enter treatment in places I worked. So now what? I'm the boss of the place. Now what? I did not exclude them from access to care because I happened to marry one of their family members. That's not their fault. I was 100% hands off in the involvement of their care. Even as a clinical director, if they needed a case review, it went to the psychiatrist. We are not doing that. Just no, thank you. If I had turned them away for care because I happened to have married their family member, to me, that's treating them different because of an existing relationship. I didn't feel good about that. At the same time, I absolutely should not be directly treating them or involved in any way at all. That's the way I chose to handle it. Okay, do not exploit relationships. I have had clients tell me that their prior counselor, in their words, convinced them to start a private business, then hire said counselor as a business partner in the business, then ghost them, move to the mainland, leaving the client without a counselor, without a business partner, and with a ton of debt and financial ruin in their business. Is it true? I don't know. I assume it is because we had a pretty good working relationship. That client and I can't think of a reason why they would fabricate that. Does that sound far-fetched? Yeah, this is why we have ethics refreshers. People do this stuff. If you ever wonder why, again, do we have to talk about ethics again? With this is why people keep violating, unfortunately. As they used to tell us in the military, if there's a rule to not do it, enough people have done it. It's unfortunate, but that's probably a truthful component. No sexual behavior with clients. It's a little sad that we need to remind ourselves about that, but once again, enough people have violated that we need the reminder. States have amounts of years to wait after treatment has finished, in which theoretically it's permissible. I would suggest just not personally, but if you're within legal parameters, I suppose technically you're within legal parameters. Okay. We may not get to the other three principles. I'll pause here in case there's feedback, questions, comments, anything I said that didn't make sense. I'll follow the lead of you all. I'll pause for a moment.
Questions, ideas, feedback?
Hopefully, kind of relatively painless for you. When I used to do this as a full CE course, it was 6 hours, and I wanted stories and examples from everyone. So you
Ooh.
won't have to do that this time.
So you're saying we're lucky.
I'm saying I'm not going to ask you to spill the beans. And that's an old saying, but I think we know what it means. But and the slides are there. It's taken directly from the Code of Ethics, not a lot different from if you printed it out, and that's on purpose. Not because I'm too lazy to design slides, but I think this is a topic that's pretty important to be very objective and specific on the factual data. At the end of the slideshow are some links to various codes of ethics, NASW, ACA, so on. So that's there if you want to. Google's also there. It doesn't take long to find these things if you want them.